Okay, good afternoon, everyone. I hope you're having a nice time at CHEST. I'm just wanting to try and get your slide. That is you? Oh, perfect, okay. I'm Dorina Drizzo-Harris. Welcome. This is a special lecture today because we are giving out one of our honor awards. We're giving out the Margaret Pfrommer Endowed Memorial Lecture in Home-Based Mechanical Ventilation. And we are honoring Dr. Howard Panitch for his work in this area, and he is going to be giving the honor lecture today. The Margaret Pfrommer Memorial Lecture in Long-Term Mechanical Ventilation was established back 20 years ago, 1999, by Drs. Eveline Faure and Dr. Goldberg. And it honors lifelong colleague and friend Margaret Pfrommer, a polio survivor and a patient advocate. It's awarded to either a clinician or ventilator-dependent professional or advocate who has advanced mechanical ventilation and fostered partnerships between physicians and patients. And it's my pleasure that Dr. Panitch is getting this award this year. Dr. Panitch is an attending pulmonologist, director of the clinical programs, and director of the Technology Dependent Center at Children's Hospital of Philadelphia. Some of his research has focused on airway smooth muscle, dynamic airway collapsibility, RSV bronchiolitis pathogenesis, and prevention and barriers to transitioning technology-dependent children to adult care. Dr. Panitch's devotion to providing exceptional patient care is routinely awarded annually by top physician honors. Dr. Panitch is very involved with CHEST. He's on the Scientific Program Committee. He's on the Pediatric Chest Medicine Network, on the Council of Networks, and he currently serves as chair of the Home-Based Mechanical Ventilation and Neuromuscular Disease Network. Dr. Panitch strives to promote clinical knowledge and enhance respiratory care of individuals with neuromuscular conditions, and we do know how complicated that can be. For his dedication in patient care, research, and the advancement of this specialty, we honor his work today. Please join me in welcoming Dr. Panitch as he presents Children Are Not Just Little Adults, Except Sometimes.
Good afternoon. Thank you, Dr. Drizzo-Harris, and thank you to Drs. Goldberg and Faure and to the International Ventilator Users Network for this honor and for allowing me to give this talk today. So I wanted to talk a little bit about the intersection of care between children and adults. One of my jobs as a pediatrician is often to remind my non-pediatric colleagues that kids are not just little adults. But sometimes in the world of mechanical ventilation, we borrow a lot from our adult colleagues, and maybe every now and then they do the same with us. So I have no disclosures other than to say that I've been a consultant for Respironics, which I don't think will really affect this talk. Before I start my topic, I do want to mention Margaret Pfrommer, for whom this talk has been named, a pretty incredible person. She acquired polio as a teenager in 1956, and after her mother died, she was forced to live in a nursing home for 2 years. She was so incensed at that care that she arranged on her own to move out of a nursing home and to live independently, which she did for the rest of her life. She also volunteered in the Northwestern University's Rehabilitation Engineering Research Center. And she worked as a volunteer because if she were to have gotten a stipend, it would have affected her Social Security benefits. Nevertheless, she became a staunch advocate for people with all kinds of disabilities. She testified in front of Congress, and she spoke with legislators at the state, local, and national level to change policy for people with disabilities. Well, she certainly was Dr. Goldberg's inspiration, as he has told us a lot. This was my inspiration. to start on a path of caring for children with chronic respiratory failure outside of the hospital. This was a little boy with pentalogy of Cantrell, which is a condition that involves midline defects, including for him, ectopia cordis, or his heart was outside of his chest. He had a sternal cleft, he had a gynum phalloceal, and he had diaphragm problems. This was his first day ever outside of our hospital when he was about 3 years old. And he was terrified by the sunlight on his face and the wind and the sounds of the cars. And you can also see the number of people it took to take this little boy out to the park just across the street from the hospital. So this was, at the time, my attending. Here's me. Here's 3 residents, a respiratory therapist, and 2 nurses. All of us a little bit terrified of this process. But it was his first time out and really made quite a difference in his life. About the time that he made that trip outside, there was a publication that came out from the American College of Chest Physicians that were the first real set of guidelines that codified the type of care these patients needed. And on that committee were 2 pediatricians, Dr. Goldberg, whom I've mentioned, and Tom Keynes, another giant in the field of long-term mechanical ventilation, and another Pfrommer awardee. And they really helped to describe the kinds of things that both adults and children required in order to not only survive, but thrive outside of an intensive care environment. And in fact, I use an adaptation of their goals for home mechanical ventilation anytime I give a talk on home mechanical ventilation. And I adapt them for children because we really do not only care about survival, but also the achievement of maximum potential for growth and development whenever that's possible. And so certainly these are things that I think both our adult colleagues and we share to do the best we can for our patients and to make this a sensible and cost-effective method of support outside of the hospital. Well, this is another snapshot from the early days that I was taking care of these patients. This is a bunch of the kids who were in, at the time, a unit that was called the Special Care Unit, or lovingly referred to as the trach unit because it was named the Chevalier Jackson Tracheostomy Unit. And this is where all our kids with chronic respiratory failure lived until we could find a place for them to go, hopefully home. But this was around the time of the Christmas holidays, and one of the big department stores in town had given all the kids who were hospitalized a stuffed bear that had this little red vest on it. And the nurses of the special care unit thought it would be a great idea for their holiday picture to dress the kids who were sort of residents there in the vests and hats that came with the bears. And this was the Christmas picture that went out that year. And while it may be cute, it really does sort of typify the problems that we had with children back in the late 1980s who had chronic respiratory failure, and that is they were growing up in the hospital, and this is certainly not the way to achieve their best potential for growth and development. Well, we had some limited choices in terms of sending kids home at that time. This is one child who went home using the same type of mechanical ventilator that we were using in the neonatal ICU. So if you can see in the background, this is a Seacrest ventilator. It provided continuous flow and intermittent mandatory ventilation. And if you look on this side of the room, here's a scale. So the table that scale sat on isn't really a table. This was the compressor in order to drive that ventilator. So it required a big compressor like this to run. It really wasn't that portable. The way we got kids portable was to give them incredibly long circuits. So you can see this is just going off into the distance. And so he was sort of confined to the room, but he could at least move about the house, and his parents had ways to get him around the house. So our initial ventilators really were tanks, but they weren't very amenable for most kids who had chronic respiratory failure because of diseases like prematurity. So these ventilators were piston-driven, they were heavy, And if you wanted to make them portable, you needed to use a car battery or a marine battery, which added more weight to the process. They were piston driven, and they really were limited in the modes of ventilation that they could deliver. So they were typically volume control ventilators, and they worked in synchronized IMV mode or assist control mode, and they didn't have continuous flow. And when you combine that with a pressure trigger that wasn't very sensitive, that really wasn't very helpful for little babies. They used an external PEEP valve that if you had a leak around your tracheostomy didn't hold PEEP very well. If there were a power outage, there was minimal internal battery capability, really just to avoid any kind of catastrophe until you could get to another electrical source. Well, in the early 1990s, people started combining one of these ventilators with a CPAP unit. And the CPAP unit could then deliver continuous flow. So here's the CPAP unit sitting atop another of these piston-driven ventilators. This is the PLV, this is the LP10. And with a one-way valve, you could deliver continuous flow to the patient. And so we were reproducing that continuous flow with intermittent mandatory ventilation for our patients. You notice this is on a platform. This is actually the bottom of a wagon. So kids could move around by having all this equipment on a wagon, but they were truly portable at this point. And if we could add a battery to it, we could really make them pretty portable. And so here's a baby home with her system. You can see it back sitting in the corner here, along with her heater. But this enabled us to send lots more kids home until ventilators evolved, and this continuous flow concept was then integrated into these newer ventilators. And so now the second and third generation ventilators really have come of age. So here, and in fact, these last three that I have depicted up here, the LTV, the Trilogy, and the Astral, all are FDA approved for use in children as small as 5 kilograms. These machines now are mostly turbine driven. They don't weigh very much. You can see the difference here. They have all the modes that we use even in the intensive care unit. As I mentioned, they provide continuous flow. Most of them have their PEEP integrated into the machine, and so they're a little more tolerant of leaks. Some of them have both a flow and a pressure trigger, so we have choices sometimes. And there's much more in the way of external battery options. In fact, these last two have graphics packages so that we can look at the interaction of patients in the ventilator in real time, and we can get downloads so that we can understand how the patient's interacting. So we've really come in the last 25 years or so quite far in our ability to care for those patients. Well, as a result of that, we've sent a lot more patients home. So these are the number of kids that have gone home from the pulmonary home ventilation program at the Children's Hospital of Philadelphia. When I first came to CHOP in 1998, most of the kids followed home with mechanical ventilation were followed through the anesthesia and critical care department by Jack Downs, another Pfrommer honoree. But over time, that's shifted to our division so that we initially took care of kids with neuromuscular disease in the pulmonary division, and now we sort of take care of anybody who requires either invasive or non-invasive mechanical ventilatory support. So we now are following about 830 children in the community who require some type of ventilatory assistance. So this is the breakdown of the types of diseases that we follow. We have kids who have a variety of airway problems like abnormal collapsibility or stenoses. We have kids with congenital heart disease. We have kids with chronic lung disease, most of whom have the sequelae of prematurity or bronchopulmonary dysplasia. We have some kids who have central nervous system disease because of metabolic problems, others with control of breathing issues like central hypoventilation syndrome. And then we have kids with central nervous system injury who develop cerebral palsy, and of course our patients with neuromuscular disease. We don't follow too many kids in our program with obstructive sleep apnea because we have a pretty active sleep program, and they follow another large number, well over 1,000 children who require CPAP or BiPAP just for OSA. And then we have a multidisciplinary program for children with a condition that's been coined thoracic insufficiency syndrome. That's the result of spine and chest wall deformity. So we have a fair number of kids with restrictive lung disease because of that. What I'd like to do for the next several minutes is concentrate on one group of these kids, which is those with BPD, and talk about how they may be the same or different from older patients who have COPD, and some of the things that we've learned from adult colleagues in the care of these patients. So for people who are not familiar with this disorder, it's only been described 52 years ago. So in 1967, a radiologist named Northway noted that some of the babies at Stanford who had respiratory distress syndrome weren't getting better as we would expect, but went on to develop chronic lung disease. And he coined this bronchopulmonary dysplasia, a term that we still use. Now, those kids that Northway described were children who were receiving high pressures, high inflating pressures, and high concentrations of supplemental oxygen, but they were also older in terms of their gestational age, and they were bigger. The kids that were described in Northway's report almost never now would go on to develop BPD. In fact, with the advent of exogenous surfactant therapy and prenatal use of steroids for mothers who are at risk of delivering preterm babies, and overall improvement in neonatal care, borrowed a lot from the principles of adults with ARDS. We have babies who now are surviving at much younger gestational ages who go on to develop this disease. So new BPD occurs in babies who now are born at a much earlier age of lung development or phase of lung development, usually around 26 weeks of gestation, and they're much smaller babies. That has led to a difference in the type of disease that these kids have. So classic BPD that Northway described, because of that high barotrauma and high oxygen tension, those babies had lots of airway involvement with inflammation, fibrosis, and smooth muscle hypertrophy. And if you looked at their lung parenchyma, there was a quilt work of opposing areas of marked overdistension next to areas of collapse, with some areas that looked more normal in between. Again, with this improvement in care of these babies, there's been a real difference in the pathophysiology of BPD in what's called the new BPD, and now the hallmark of new BPD is one of alveolar simplification, and it seems to be that there's an arrest in alveolar development, so these babies have fewer, much larger air spaces and pulmonary arteries. They do get some airway disease, but it's not as severe as in classic BPD, and if they have fibrosis, it's usually much more uniform. Well, I've mentioned a couple times that care has improved. Neonatologists have adapted ARDS-NET criteria for ventilation, although they don't necessarily use 6 per kilo. They may use 3 or 4 mils per kilo of a tidal volume. But even so, with all of those strategies, with the use of high-frequency ventilation, et cetera, the incidence of BPD over the years has not gone down. And in fact, from a very large database, there's a suggestion that over the years, the incidence of BPD has actually gone up, and that's because we continue to save younger and sicker babies, and then they go on to develop this chronic lung disease. Well, one way that the lung disease is quite different in babies from adults has to do with airways. And so there's a real difference between a baby's airway and an adult's airway in terms of its mechanics. So on the left-hand side of this slide is a pressure volume curve looking at isolated tracheal segments from human autopsy specimens. And you can see this is pressure, distending pressure and collapsing pressure, and a change in volume relative to resting volume of the airway. And so the younger you are, the more compliant the airway is. So that with very little distending pressure, you see a big change in volume for the infant and a marked collapse with just a little bit of negative or collapsing pressure. And as you age, that gets to be less and less. So the airway with maturation becomes stiffer. In an animal model, that can be extended into the preterm period. And so this is a model, same construct with distending pressure, collapsing pressure, and change in volume over resting volume. But now looking at rabbit isolated tracheae that go from adulthood through late gestation, maybe that 26-weeker in terms of humans, and you can see that there's that same maturational change in compliance, that the more immature the baby, the more compliant the airway is. In fact, these airways are more compliant than the lung parenchyma for an infant who has respiratory distress syndrome. And so what we know can happen then is if you apply positive pressure to those airways, they get deformed. And then once you remove that positive pressure, they can be abnormally collapsible. So they behave sort of like a fire hose, so that when you distend them fully, they may be stiffer, but as soon as you relieve that distending pressure, they become quite collapsible. Well, that was described. So this is an infant with BPD who required chronic mechanical ventilation via tracheostomy. This is a fluoroscopy study, and you can see the tracheal lumen is much smaller than this 3 or 3.5 millimeter tracheostomy tube. So on exhalation, there's dynamic collapse of that airway. In terms of overdistension, this was a study that compared babies who were born prematurely who required mechanical ventilation, and they were age and gestationally matched with babies who did not require mechanical ventilation. And then the investigators just looked at AP and lateral radiographs to look at tracheal dimensions. And they looked at the AP view for the tracheal width and at the lateral for the width, and so that they could sort of estimate the volume of the trachea. And they showed that all the babies who required positive pressure ventilation had relative tracheomegaly compared with those who did not. And they speculated that maybe one reason that these babies developed elevated PCO2s after extubation is that they had a much larger anatomic dead space as a result of just a couple of weeks or even less of positive pressure ventilation exposure. More recently, one of our former fellows looked at the effect of Tracheobronchomalacia on outcomes of infants with BPD. So Eric Heisinger reviewed a large database that involved 27 centers and about 8,000 babies. And of those, about a little less than 1,000 had undergone bronchoscopy for one reason or another. And then he looked at that group, comparing those who did require, who did have a diagnosis of tracheobronchomalacia versus those who did not. And just a few pieces of data that he showed were that those kids who were diagnosed with tracheobronchomalacia by bronchoscopy had a longer length of stay, and that was almost all attributed to an extra 3 weeks of mechanical ventilation versus those who did not have tracheobronchomalacia. And so when they went home, they were older at time of discharge. So tracheobronchomalacia extended duration of hospitalization, duration of mechanical ventilation, and it was associated with several other morbidities. So in and of itself, it's a problem for these kids. Well, when we think about this collapsible airway, I've already talked about the inherent characteristics of the airway, how stiff it is. But the other thing that we have to think about is the pressure that's applied across that airway wall, or the transmural pressure. And this is important in anybody who has an obstructive lung disease. As we know, if you apply higher transmural pressure, if you cough, or if a baby cries, a baby can collapse that airway, even if it's not abnormally collapsible. But if you combine those two things, that could be pretty detrimental for ventilation. So this is an example of that. We took isolated tracheal segments from lambs who were newborns and I promise didn't have wheezing. And we developed a plethysmograph where we could mount the tracheal segment and then put a bronchoscope through it. And we could alter transmural pressure across the airway wall. So here's a tracheal segment with no transmural pressure across it. And here's that same segment when we just put 40 centimeters of water across the tracheal lumen, and there's about a 75% reduction in cross-sectional area of that airway. Now, I have had esophageal catheters in infants when they cry, and they can easily generate over 100 centimeters of water pressure in the pleural space. So this is a pretty modest transmural pressure difference across that trachea that causes a pretty significant reduction in cross-sectional area. We know we can change the characteristics of the airway wall in a couple of different ways, one of which is by stimulating airway smooth muscle. So here is this same airway now exposed to a cholinergic agonist, methacholine. And you can see there's very little difference in the resting cross-sectional area of that airway. But when we apply that transmural pressure difference, that airway is much less likely to collapse here. In fact, there's a marked reduction in collapse just as a result of stiffening the airway wall. And that's a strategy that we've used in some of our babies who have severe tracheomalacia. So this is a study that we did sort of as a proof of concept in 3 babies who had bronchoscopically proven tracheomalacia. All of them had tracheostomies. 2 of them were still ventilator dependent. And these are partial flow volume curves that we conducted by using something called the rapid thoracic compression technique. So babies would be breathing, and I'm going to use, so here's patient 1, patient 2, and patient 3, and these are their baseline studies. So let me just show you patient 1. So this baby would be breathing. This would be inhalation and exhalation. And then at the end of, once we establish that this baby's breathing pattern is stable with a stable FRC point, at the end of a breath in, we would rapidly inflate a vest that surrounded the chest and abdomen that would squeeze the chest and abdomen and make the baby forcefully exhale. And so here you see a forced exhalation, and expiratory flow is actually lower than tidal flow for this baby. Same thing with this one. This baby wasn't quite as severe. We then gave these babies gradually increasing doses of methacholine, and we showed that we could increase forced expiratory flow in each of these cases. And then we gave these babies albuterol to relax airway smooth muscle and showed a marked reduction back to baseline or even lower in this third one. So altering smooth muscle tone can have a big influence on how the trachea behaves, and it's something that we now use in lots of our ventilator-dependent kids who have tracheomalacia. The enteral drug that we use is bethanechol, and we also use ipratropium inhaled in low doses to increase central airway smooth muscle tone and help these kids avoid some obstruction. Another thing that's commonly used is distending pressure. So here was a group of babies that we studied who had, again, bronchoscopically proven tracheobronchomalacia, and we gradually increased the distending pressure from no CPAP, 5, 8, and here's 15. And you can see that this baby at increasing levels of CPAP had higher and higher flows until we actually normalized this expiratory flow volume curve. And for the group, we saw significant increases. So using distending pressure is another strategy and is one way that we help set that level of PEEP for our patients who require chronic ventilator support. One of the things that we have to keep in mind, however, is that transmural pressure gradient. So if babies also have severe small airway disease, they may always forcefully exhale. And so I liken this to adults with COPD who may also have collapsible small airways, who also have to use positive pressure to exhale. And even if that airway intrinsically is not collapsible, it may behave as such because that patient has to use positive pressure to overcome small airway obstruction. So let me talk a little bit more about that, because both in patients with COPD and in our babies with BPD, this is a big deal. So these are micrographs from a mouse model, and these are normal lungs. And this just shows the effect of lung volume on airway size. So here's the mouse at FRC, And the arrows are pointing out 2 airways, and you can see their size. And then at total lung capacity, you can see how much larger these airways are. And that is because you have to think about these airways, these small airways, as sort of suspended in a nylon stocking. And as you stretch that mesh, those little nylon attachments pull open the airway. Well, it's the same thing with alveolar walls. So as the lung increases, alveolar wall attachments to that airway pull it open and dilate the airway. But what happens if you have a disease where you either don't make those alveolar wall attachments because you had alveolar arrest, or if you're an adult, you have destroyed alveolar wall attachments. You don't get the same elastic recoil, you don't open those airways to the same degree, and those patients are at risk for obstruction. So that's a big deal for us, and it changes the way we think about long-term ventilation of our kids with severe BPD. This is one of those infants, as we're trying to understand where his PEEP should be set to help him and what kind of ventilator strategy we could use. I think you can all recognize that there is incredibly heterogeneous lung disease in these patients. And so we have to take that into account. And this is one place where we may differ from our adult colleagues, because once a baby has established severe BPD, so we use the low tidal volume general ventilation technique, but once severe BPD is established, we have to switch strategies, because if we were to continue to use that low volume rapid respiratory rate technique, then because of the heterogeneity of the lung disease and different time constants, we would only be ventilating those regions of the lung that had the shortest time constants, and we wouldn't really be ventilating these other areas. And so we adapt a different strategy for these babies using larger tidal volumes, lower respiratory rates, in order to get more of the lung involved in ventilation. And so the strategies that are now being used in these kids who really have severe lung disease and require probably a year or 2 of mechanical ventilation is that we use larger tidal volumes, and maybe even larger than 12 per kilo, maybe up to 14 or 15 per kilo, while we still allow for elevated CO2s, so we don't try and ventilate them to a normal CO2. We use a lower respiratory rate to allow them to empty, and we use longer inspiratory times to allow them to fill. That really is an important strategy. And then how we set PEEP really depends on the problems that these babies have. So I want to spend a couple of minutes and talk about that. Because when people talk about optimal PEEP, optimal, like beauty, is in the eye of the beholder. So we can use PEEP and set optimal PEEP if we're really worried about lung mechanics. We can use PEEP, as I showed a couple minutes ago, to offset Tracheobronchomalacia. Or, as I'll show you in a moment, we can use it because these babies, like our adult counterparts who have COPD, often have intrinsic PEEP. Well, here's another place that, at least in our institution, we have borrowed heavily from our adult colleagues. So we try very hard not to set PEEP in a vacuum, but instead we use mechanics measurements. And so we will change the ventilator strategy temporarily to a volume control mode, have the baby sleeping or maybe sedated, and we use a simplified equation of motion of the respiratory system that says the pressure to get the air into the alveoli is that has to overcome the stiffness of the lung or its resistance to being stretched, how much we want to stretch it, the resistance of the lung and airways, and this should be flow. The dot was left off here, and how fast the airflow is. And so we can just extend the inspiratory time in a sleeping baby, and that will result in a period where the ventilator valve is left open, but there's no flow. And so then we get that very nice pressure plateau, and we can measure mechanics very nicely because we get rid of this term since there's no flow. So now all the pressure that's being applied has to do with how stiff the lung is and how much we're trying to change the volume. And then we can just adjust PEEP, and we can do what we call PEEP grids and figure out where we might want to establish PEEP for a given patient. So this particular patient had PEEP varied between 6 and 16 centimeters of water. And if we're using compliance of the respiratory system as our target, we would probably say that this baby would do best at a PEEP of 8, because as we distend the lung more, it looks like we're over-distending it. Now, some babies have pretty heterogeneous disease, as I mentioned, and they do develop intrinsic PEEP. We can use the method that's common in the adult world, which is to do an expiratory hold in a patient who is paralyzed or heavily sedated, so we don't want them to breathe. And here, we apply an expiratory hold, and we see that there's an increase in PEEP as we keep that valve open. I should mention that this company, for this ventilator company, does not allow you to do this maneuver in neonates. There's no such thing as an expiratory hold. I guess they either don't think that those kids have intrinsic PEEP or they don't trust us to do that. But we don't like to paralyze patients if we can help it, and so we've borrowed from the adult world another technique which uses an esophageal catheter. So here we have esophageal pressure tracings. Here's flow at the airway opening, and here's pressure. And you can see a couple of things here. So this is a baby with intrinsic PEEP. Look at the esophageal tracing for a moment, and notice all these times that that baby is trying to take a breath, but never triggers the ventilator. So these are wasted efforts. And what we can do is look at where that baby starts to take the breath, or at least wants to start to take a breath, and there's a trigger delay here. So we see that there is the delay, and then we can look at the pressure difference between those two, and that pressure difference is the intrinsic PEEP the baby has to overcome in order to trigger the ventilator. And we can set the ventilator with that in mind as we work on getting the baby's lung disease better. So folks have reviewed our use of PEEP in our NICU. We have a large chronic lung disease referral service. And so for 58 babies, they came in with a PEEP of about 11. As we increased PEEP, there was a modest reduction in the amount of oxygen these babies need, and a third of them we were able to reduce PEEP by using our mechanics measurements. If a baby came in with a PEEP of 11 or more, it was likely that that baby needed a tracheostomy at time of discharge, and if we had to increase PEEP, it increased the risk that that baby either didn't survive or would go home requiring prolonged mechanical ventilation. This is the first child that I sent home on a PEEP over 20 centimeters of water. This was his radiograph at the time. You can see his massive overdistension and how simplified his lung was. And here he is about 18 years later taking a cooking class. He does enjoy some ventilator-free time, but he uses his ventilator most of the day and night. And his mother was very anxious for me to show his picture and to emphasize what a great life her son is having and how much he means to the family and to people around him. He's in a regular school, and he's an inspiration for students and teachers alike in his community. All right, well, I want to switch gears now and speak a few moments about our patients who have neuromuscular disease, because this truly is a place where we have borrowed heavily from our adult colleagues, many of whom are in the audience. So John Bach, another Pfrommer lecturer, reported on different ways to clear airways, and this study looked at methods in adults with neuromuscular disease to increase cough peak flow above a critical value. Here in liters per second, it was about 3. Of course, we know that this translates into about 270 liters per minute. And he showed that you could increase your cough peak flow by doing breath stacking alone, using breath stacking with a manually assisted cough, or using the mechanical in-exsufflator. And so when he published these data, I asked him to come to speak to us and our group, and I think we all very quickly drank the Kool-Aid and started using mechanical in-exsufflation routinely in our patients with neuromuscular disease. Well, fast forward a few years, and one of our nurses, Lori Miskey, who's in the audience, reported our experience with the use of mechanical in-exsufflation in our population, ranging in of patients with neuromuscular disease, ranging in age from 3 months up to 28 and a half years. For most of these patients, it was quite well tolerated and it was safe. There was only one adolescent with Duchenne muscular dystrophy who developed PVCs the first time he used the in-exsufflator. We had cardiologists come see him, adjusted his medications, and he began to use the in-exsufflator without difficulty thereafter. Subsequent to this report, we had another patient with Duchenne muscular dystrophy who required continuous positive pressure ventilation, and he used a mechanical in-exsufflator. He developed a pneumothorax, and we don't know which of those positive pressure exposures caused it, but that might be our only other complication. Most of the patients, as I said, tolerated it. Very few patients required hospitalization or had pneumonia, but 5 did express that they had fewer pneumonias with its use, and 4 had improvement in chronic atelectasis. Importantly, we couldn't tell from age or even underlying disease what pressures to use. This was something that had to be adjusted for each patient. And so for that group of 62 patients, the median insufflation pressure was 30 centimeters and the exsufflation pressure was minus 30 centimeters. But you can see there were pretty big ranges. We asked patients to use this twice daily, routinely. Most did that. Some would only use it when they were sick, but we tried to discourage that and ask them to at least be facile with its use in case they were to get acutely ill. And with its use, we could have great results like this. This was a 22-month-old little girl with SMA1 who was admitted with an acute right upper lobe density and respiratory distress. And just 1 day later, we were able to markedly improve her underlying respiratory condition. Lori then went on. We often would get into a conundrum where our patients would come in for a surgical procedure, and the surgeons would say, "You can't use the cough assist in the post-op period because you'll dehiss my wound." And so we decided to see if we could debunk that. So Lori collected 13 patients who had neuromuscular disease, who already had gastrostomy tubes, and who already were using mechanical in-exsufflator, and using Respitrace to look at the relative change in chest wall and abdominal volumes, and using the gastrostomy tube to measure gastric pressure as a surrogate for intra-abdominal pressure. She had the patients use their cough assist devices at their usual pressures. And so the gastric pressures that we measured were pretty small, and it was only about half of what we applied at the airway opening. There were 3 patients who could generate a spontaneous cough, and you can see that their pressures, 7, 10, and 25 centimeters, were pretty much within the same range as the mechanical in-exsufflator, and the abdominal volume didn't go up very much. And so it's our view that where the patient really needs that airway clearance in the immediate postoperative period, using an in-exsufflator is still quite safe and something that we would encourage be done. Another place that we drank the Kool-Aid was in believing that continuous, non-invasive ventilation is not only reasonable, but sometimes quite preferable. And one of the heroes of that for me is Josh Bendit, who's in the audience. And of course, Dr. Bach has written a lot about this. And so these are the types of patients that we consider as acceptable for using mouthpiece ventilation during the daytime. They have to have adequate buccal strength. They have to be able to swallow. They, of course, have to be alert and cooperative. And so we began using mouthpiece ventilation perhaps about 15 years ago, fairly successfully. So this patient on the left, I think this was my first patient that I used mouthpiece ventilation in. And he now has transitioned to our adult care program well into his 30s. He has a degree in history, and he's a substitute teacher. The young man on the right did not have adequate buccal strength. He couldn't keep a mouthpiece in his mouth, or when it would deliver positive pressure, it would just leak out of his lips. And so we figured, well, why not just use a nasal interface? And so he continues to use this, and His father told me shortly after we started supporting him in this way that now the family goes out to dinner again, they go to sporting events, he goes to the casino. It has so changed his life and improved his quality of life. So we're real believers in this approach. To sort of come full circle, I started to think about this for our babies with BPD. So this is an infant who was born at 30 weeks, but his mother had oligohydramnios at about 26 weeks. And he has pretty severe overdistension. And this is him using a nasal interface. Which I think you can see doesn't really interfere with his ability to perform therapies and to play. And so he uses a nasal mask at nighttime, and he uses a nasal interface during the day. And our goal, of course, is his growth and development, but hopefully we're avoiding a tracheostomy for this child. He's now home using this continuously. Well, I would be remiss if I didn't mention teamwork, and this is something I think that our adult colleagues and pediatricians have in common, and something that the college champions, the idea of interdisciplinary care. This is my group of superheroes. This is a team of people who do pretty incredible things that often are short of extraordinary in getting services for our patients at home. This group consists of nurses, nurse practitioners, dietitian, social worker, respiratory therapists. And they really managed to do some incredible things to keep our kids safely at home, keep them out of the hospital, and provide incredible care for them. And there's no way that any of us could do this without having this type of support and working as a team. Certainly, having 830 kids in the community couldn't be done with something short of this group of people. And so we get great outcomes like this. So a bunch of kids who are able to be decannulated, liberated from mechanical ventilation and decannulated. This young man was decannulated, but again, borrowing from our adult colleagues, he still requires supplemental oxygen, so he uses a transtracheal oxygen catheter. But these folks were decannulated and are on and about life. But there's another group of patients that still are doing much better than they used to 25 years ago. And there are patients who continue to require chronic mechanical ventilation. These are data from the Pennsylvania State Children's Home Program, or the Ventilator-Assisted Children's Home Program, that looked at the number of children who were able or about to turn 21. And between these two epochs, between early 1990s and early 2000s, there was a fivefold increase in those patients. And so transition to adult care has become not only desirable, but a necessity for this group of patients. We're really fortunate. At Penn, we have now for the last 2 years had a transition program with our adult counterparts who developed a wonderful team, and one of our former fellows who was MedPeds trained, who sort of crosses both sides of the aisle and takes our patients from the pediatric world into the adult world, along with some wonderful adult colleagues who have learned about SMA and Duchenne muscular dystrophy and some of the other pediatric diseases that result in chronic mechanical or chronic respiratory failure. And so I'll end by saying these are the challenges that I think we have. We still have to improve the quality of life of our patients in a cost-effective way. I think we have to maintain and in many cases improve the services they get. We lost the Ventilator-Assisted Children's Home Program in Pennsylvania, which came with some respite care for families. And so, it's inconceivable to me that physicians and insurance companies think that it's reasonable for people to provide critical care to patients 24 hours a day, 7 days a week without any break. And so I think we still have to lobby for those respite services, not only for children, but for adults with chronic respiratory failure. We have to be nimble and be able to integrate new technologies like telemedicine into the care of these patients. And of course, individualized care, so we find the best for patients and their families. And so I want to leave you with a quote from Margaret Pfrommer. While I never had the opportunity or the privilege to meet her, I think she inspires me. I think she inspires many in the audience. And as she says here, I do not mind failure. However, I do mind going through life without having tried. Thank you all very much for your attention. And thank you.